My name is Kenton Wong, and this is a clinical vignette about Thromboangiitis Obliterans in a demographically atypical patient, created with the help of Dr. Christopher Moreland at the University of Texas, Del Seaton Medical Center. Thromboangiitis Obliterans, formerly known as Buerger's disease, is a vasculitis of the small vessels of the hands, typically occurring in adult male smokers. The exact pathogenesis of the disease is still poorly understood, but the histological hallmark is inflammatory intraluminal thrombi of the small and medium vessels of the digits, which spares the internal elastic lamina. The case that follows describes a patient who presented with these classic characteristics and risk factors, but fell outside of the typical demographic affected by Thromboangiitis Obliterans. A brief description of their hospital course and teaching points will follow. This 70-year-old woman traveled by RV and therefore had fragmented care. She presented to the ED during winter with acute pain and discoloration of her fingers and toes. She had a smoking history of approximately 27 pack years and a past medical history of hyperlipidemia, Barrett's esophagus, breast cancer, which was treated with surgical resection, and osteoporosis. In the 6 to 8 weeks leading to her presentation, she noticed some pain and discoloration of her toes and fingers. On arrival, the patient was hemodynamically stable without acute distress. She was noted to have dry necrosis of her right middle finger and the tips of multiple other fingers, her left second, her left third, and the nail beds of multiple other digits. Her right great toe was also discolored with some erythema and localized swelling of her right foot. Broad-spectrum antibiotics were started for potential endocarditis. Surgical consults were requested for potential management of this patient's necrotic digits. The patient was admitted with a broad differential, which included septic emboli from endocarditis, other thromboembolic disease, a vasculitis, or peripheral arterial disease. While inpatient, she received a transthoracic echocardiogram, which demonstrated no vegetations, and 2 sets of blood cultures returned no pathogens. Other tests were conducted, including anti-nuclear antibodies, a Sjogren's panel, ANCA, PR3, MPO, cryoglobulin titers, a scleroderma panel, creatine kinase, hepatitis B and C titers, HIV, and antiphospholipid antibodies. These were all negative. Due to the diminished likelihood of infectious etiologies, antibiotics were stopped. She was discharged after 2 total debridements with plans for outpatient rheumatology follow-up. This patient experienced subacute digital ischemia and necrosis outside of the typical demographic affected by TAO. Her age and gender both suggested initially that TAO might be less likely. According to studies, men are more commonly affected than women in this disease. Of patients diagnosed with TAO, 70 to 91% are male, and 11 to 30% are female. The majority of patients present before the age of 45. This case was notable both for its unusual presentation and the extensive workup that the patient received, which was required to rule out other vascular or rheumatological conditions. In this patient, TAO was initially lower on the differential due to the aforementioned factors of age, gender, and subacute presentation. Definitive treatment for TAO is smoking cessation, which the patient had already initiated. This case highlights the importance of maintaining suspicion for conditions in the setting of pathognomonic findings, in this case, distal digital ischemia in a smoker, even when the patient does not match a typical demographic for the specific disease. Thank you for your time.